Hi everyone, and welcome to Chapter 18, Caring for Clients with Cancer. Here are the learning objectives for the chapter. You can also find these on Blackboard. I have it in the form of an escape room if you would like to do that rather than answer the questions this way. It's just your choice. So cancer is when the body's own cells replicate unchecked. Normal cells have a regulatory mechanism, and that tells them when to stop. However, cancer cells don't have anything that regulates them. Now, cancer is classified by growth and tissue type. So we have carcinomas that are associated with epithelial cells, lymphomas that are organs that fight infection, the leukemias are related to the blood disorders, and sarcomas are more connective tissue and bone disorders. Now, a well differentiated cell looks like a normal cell, and that tends to grow and spread more slowly than a poorly differentiated or undifferentiated cell. Differentiation is used in tumor grading systems, which are different for each type of cancer. So tumor growth is either going to be benign or malignant. So with your benign tumor, those are generally considered harmless, and they generally don't cause any problem because they're very non-invasive. However, they do grow large. Now, because they can grow large, they may impinge or affect blood flow to an area or an organ, and that can cause some problems and possibly even death, depending on which organ they're affecting. Now, a malignant tumor is very invasive. It has uncontrolled growth. Remember, those are those undifferentiated cells, and so they're not regulated, so they just grow all the time, and they can alter the cell membrane as well as fluid in and out of the cell. And these type of tumors also have tumor-specific antigens that they excrete, and you can find these in certain blood samples that you're doing to diagnose cancer, like a PSA or your BRCA genes. Now, the term cancer is very discouraging to a client whenever they hear that. So be ready for that type of reaction from your client. So metastasis is whenever you have that cancer that is developed from a primary tumor. So it develops and it spreads through that lymph node system and eventually gets into those blood vessels and then into a cavity, body cavity, or to an area like that. So carcinogens are very malignant in their transformation, so whenever they move from one area to the other. And like I said, it's very progressive and invades adjacent tissue, and that's how it metastasizes. It just invades other tissue via lymph nodes or blood vessels. So cancer is the second leading cause of death in the United States. 1 in 2 men and 1 in 3 women develop cancer at some point. As you see, lung cancer is the most common. So when cancer occurs, there's damage to that DNA. You have that mutated gene that occurs, and you see a lot of the gene mutation with your breast and ovarian cancers. So what are contributing factors, or what are some things that can cause cancer? Well, we have chemical agents, environmental exposures, even our diet. So diets high in fat and nitrates, alcohol, even obesity can lead to cancer. Then look, we have certain viruses and bacteria that can also lead to cancer. So you have your H. pylori that is very prominent in your gastric cancers. So age is a risk factor as well. You have a higher incidence in older women, and with older women, you have colon cancer, breast, lung, and pancreatic and ovarian cancer, whereas your older men have lung, colorectal, prostate, pancreatic, and gastric cancers. You also see cancers in patients with chronic irritations and tissue trauma, such as burns and scars. Race can also be a factor. Caucasian women are more prone to breast cancer. However, the mortality rate in African American women is higher. For Caucasian men, you have a higher risk of testicular cancer. With your African American men, it's prostate cancer. Know that genetic predisposition also plays a factor, as well as sexual lifestyle, multiple sex partners, and STIs. Poverty, substance abuse, and chronic disease can also be contributing factors or risk factors for developing cancer. As you see, certain medications, so you take those immunosuppressive drugs or those hormone replacements, and they can be a contributing factor to causing some cancers. And know that some immune disorders, so if you have an immune disorder, you already have a defective genetic predisposition, and because of that, that will set you up for developing malignant cells or not developing cells to fight off that cancer. So now we do have a lot of complications associated with cancer, as well as some emergencies. So some of the complications are like malnutrition. So if you think about it, someone with cancer or they're receiving a cancer treatment, they may be a little nauseous, anorexic, may have lack of appetite. So that's going to cause some malnutrition in that patient. Constipation, gastric stasis, intestinal obstruction can also be a complication, as well as your paraneoplastic syndrome, which is a result when T cells in the body attack normal cells rather than the cancerous cells. And this leads to neuro changes, such as changes in movement, sensation, and even some mental status changes. Now, as far as our emergencies go, you all know what SIADH is, so you need to know those signs and symptoms because that's an emergency, and you need to be aware of that in your client receiving cancer treatment or with a cancer diagnosis. Hypercalcemia, as well as superior vena cava syndrome. And this is when there is an obstruction of the venous return and engorgement of the vessels from the head and the upper body. So it can cause an impingement and affect that blood flow. We also have hematological disorders, not only anemia, but we can have that DIC, which is your loss of your clotting factors. And these are all emergencies of your cancer or cancer treatment. So some of your signs and symptoms associated with cancer could be things like headache, weight loss, chronic pain, persistent fatigue, low-grade fever, or infections. Now there's a mnemonic here that's very helpful in your cancer assessment, and you can use this. It's called caution. So the C is for changes in bowel and bladder habits. A are for unhealing sore or ulcer. U, unusual bleeding. T is for a thickening lump. I is for indigestion. And O is for obvious change in size of a wart or a mole. and N is your nagging cough. So this is just a really nice little acronym that you can use in developing your cancer assessment. And also know that there is your ABCDE for your skin assessment for your skin cancer as well. So cancer prevention, how do we go about doing this? Well, education has got to be key. Awareness of those warning signs and factors that can cause and develop cancer. So, staying out of the sun, applying sunblock, eating a diet high in antioxidants, those kind of things, educate the client. Cancer screening programs, such as, your mammograms and pap smears, periodic physical exams. These are very important because they can you can follow up on those signs and symptoms there. Emphasize and teach self exams, self breast exams, skin exams, and testicle exams. It's very important that you teach self exams. And then again, avoid those risk factors. Smoking, avoid those chemical exposures, try to reduce those risk factors. Get your diet under control, lose weight, those kind of things. Reduce those factors. So here are the more common screenings that you should teach your client about. For instance, the mammogram should be done yearly. A self breast exam, you do that 2 or 3 days following a period. If you have irregular periods or menopause, you do it the same time every month, preferably while in the shower. With your breast exam, use the palm of the hand in a patting motion, and then use the finger pads, like the middle 3 fingers, the pads of those, to check for any thickening areas. Stand in front of the mirror, do a mirror check. You're going to look at the size, contour, look for any dimpling or discharge. With your pap smear, that's your cervical cancer detection there, so you have that done every year. With a testicular exam, the testicles should be gently rolled to feel for any abnormalities there. And then a colonoscopy should be done every 5 years, starting at age 50. Another name for a colonoscopy could be a flex sigmoid or a flex colon or something like that, but make sure you have the colonoscopy starting at age 50 every 5 years. And then it depends on the polyps and how many they find, or if they find any. And then do a yearly occult blood, and you can do this by either a digital rectal exam or just collecting a fecal exam, but that's done on a yearly basis, and you're just going to be looking for occult blood at that time for your rectal cancers. So we detect cancers one way by lab tests, and we do those specific organ function tests, those tumor specific markers like the renal, pancreas, thyroid, and liver. We can do cytology and sputum. We can also look at the hemoglobin because you want to see if there is any of those leukemias. So we're going to look at the hemoglobin, those RBCs, and those platelets. We're going to see if that patient's at risk for any bleeding, what's their platelet level. X-rays are very helpful. We do CT scans and PET scans, MRIs. Going to look for tumor location, size, and volume. So we can do MRIs, nuclear med studies, PET scans, ultrasounds, fluoroscopies, endoscopies, and biopsies. So now biopsy can be, frozen sections, or it can be cytologies, and you can get biopsies in the form of like a shave biopsy, which is a thin layer of skin you may remove, shedded cells that you would get from a pap smear, or secretions that you could get from sputum. You can even get urine and look at that. A needle biopsy, they can draw fluid or tissue with a needle biopsy. like I said, incisions or excisionals. You're going to look at those tissues under a microscope, because that's what you're looking for, are those abnormal cells to help you diagnose that cancer. So how do we go about staging and grading a cancer? So stage 0. This stage describes cancer in situ, which means in place. Stage 0 cancers are still located in the place they started and have not spread to nearby tissue. This stage of cancer is often highly curable, usually by removing the entire tumor with surgery. Stage 1. This stage is usually a small cancer or tumor that has not fully grown deeply into nearby tissue. It is also not spread to the lymph nodes, nor has it spread to any other part of the body, so it's often called early stage cancer. Stage 2 and 3. In general, these two stages indicate larger cancers or tumors that have grown more deeply into nearby tissue. They may have also spread to lymph nodes, but not to other parts of the body. Stage 4 means the cancer has spread to other organs or parts of the body. It may also be called advanced or metastatic cancer. Now, as far as our grading systems differ depending on the type of cancer it is. So in general, tumors are graded 1, 2, 3, and 4, depending on the amount of abnormality. In grade 1 tumors, the tumor cells and the organization of the tumor tissue appear close to normal. These tumors tend to grow and spread slowly. In contrast, the cells and tissue of grade 3 and 4 tumors do not look normal, and the tissue doesn't look normal either. Grades 3 and 4 tumors tend to grow rapidly and spread faster than tumors of a lower grade. There are so many treatments with cancer, and we're coming out with new treatments almost every day. So first, let's start with surgery. Surgery is a primary method of diagnosing, staging, and treating cancer. So with surgery, we can do a tumor excision, which is local. We can also do some debulking or cryoreductive surgery, as well as salvage surgery, which is local as well. An example of salvage surgery is a lumpectomy or a mastectomy. A prophylactic surgery we can also do, or preventative, whichever one you want to call it. And that's because there is a family history or genetic predisposition for cancer, such as breast cancer. Say the client has a family history of breast cancer and that they're also positive for that BRCA gene or that HER2 gene, that gene that says that they are going to develop cancer. So they choose to do a prophylactic or preventative method and go ahead and have surgery to do a bilateral mastectomy to reduce any chances of cancer development. Other types of surgery could be a palliative. Say that there is a tumor that's pressing on an organ, or that the patient has a lot of fluid buildup. So we can go in and debulk that tumor, or we can pull off that extra fluid and relieve that patient of any discomfort. So we can have a palliative surgery. Also, there's surgery for reconstructive purposes. This is more your plastic surgery, and they correct any defects as a result of the treatment itself or as a result of the cancer itself. Now, Mons surgery is whenever they shave off layers of skins. Now, you see this Mons surgery lots of times with skin cancers. And oftentimes after they do that, they may do a little chemical surgery, and that's the application of some type of chemical to the skin that will help remove that as well. We also have electrosurgeries and laser surgeries. They're becoming more popular these days. So know that anytime you're going to have that patient that's going for surgery, you need to make sure that you look at their lab work closely, see what their hemoglobin is, see what their bleeding times are, see what their clotting times are, look at those platelets prior to surgery, and notify the physician if you see anything that could cause the patient to bleed during surgery. So now let's move on to radiation. So radiation is a treatment where we destroy those cells by breaking down strands of the DNA molecule, and that prevents the growth and division of those cancer cells. Now you can have external radiation, which is your ERT radiation, and they target large tumors in the lymph nodes. Internal radiation therapy is like your brachytherapy, and with your brachytherapy you have the interstitial implants or the intracavity implants, and they release radiation over a period of time. You can have oral medication, especially like your iodines. They can be delivered orally. You can also give it IV or by the body cavity. So radiation treatment is associated with some pretty significant side effects, such as alopecia, erythema, discrimination, stomatitis, xerostomia, anorexia, nausea, cystitis, even pneumonitis, and fatigue. So your patient may have some of these as a result of their radiation treatment. They may also have some myelosuppression, which is the depression of the bone marrow, leukopenia, which you already know is decreased white blood cell count, thrombocytopenia, which is their decreased platelet count. They may have some fibrosis also develop in the small intestines, lung, bladder, eyes, and it can also cause some sterility and even the development of some new cancers. So know that with that radiation treatment that the patient maybe have to be placed on neutropenic precautions because of those decreased white cells. So keep that in mind whenever you're reviewing that lab work. So whenever you are caring for a client who is receiving radiation treatment, make sure that you are following the facility guidelines for caring for that client. Some of the guidelines would include the following: length of exposure to a client, so make sure that you're clustering your care so that you don't stay in the room very long. When you are in the room, try to maintain a far distance if possible. Make sure that you are wearing your proper equipment, that it's lead lined, that the apron that you're wearing shields you all the way around. If there's any contaminated articles, make sure that you are disposing of them properly, and always handle anything and everything with gloves. If they're receiving some type of oral radiation, make sure that you're flushing that toilet at least twice to avoid exposure to yourself and to others. So be sure to follow any facility policy regarding handling of the radiation material. In your book, there's an excellent table regarding nursing guidelines for chemotherapy treatment. Make sure that you review the guidelines in the book. So with chemotherapy, this is the anti-neoplastic agents, and they interfere with the cellular function. So routes of chemotherapy drugs can be IV. If you're given that drug IV, you're going to be giving it through a PICC line, a Hickman catheter, or an implanted vascular device. You can also give chemotherapy drugs orally, IM, sub-Q, topical, intrathecal, and intraperitoneal. So make sure that whenever you are handling any type of chemotherapy drug that you are wearing your gloves, and make sure that you review any policy procedure regarding handling of cancer drugs that they're receiving. So just like radiation, chemotherapy also has some pretty nasty side effects, and they include nausea, vomiting, stomatitis, alopecia, myelosuppression, and fatigue. So as nurses, you need to make sure that you are checking those platelet count, the white count, the hemoglobin. You're going to be looking for that thrombocytopenia. Know that you may have to initiate some neutropenia precautions should the client need that, and help them with their dietary choices. You want to make sure that they avoid any fatty foods because that might make them nauseous. Avoid any spicy food because of the stomatitis. If they have any metallic taste in their mouth from some of the chemotherapy treatments, maybe offer them some sugar-free gum. Monitor that mucosa for any fungal infection that may incur. Notice if there's any bleeding in their gums, and that could be attributed to that decreased cell production in the bone marrow as a result of that chemotherapy. And always wear protective clothing and gloves when handling any of the chemo drugs yourself. Make sure that you encourage fluid intake. Encourage that patient to drink 2,500 to 3,000 milliliters of fluid a day, and that should be in the form of bottled water, because bottled water doesn't have a tendency to be food-borne bacteria in that. So make sure that you're increasing their fluid intake. Monitor for signs of gout, joint pain, and edema, and of course offer those small frequent meals. If your patient has any changes in their weight, which is excessive, any changes in their level of consciousness or paresthesia, make sure that you report that to the physician as soon as possible. So peripheral stem cell treatment, which is a transplant, and that replaces bone marrow destroyed by cancer or cancer treatments, and it's in the form of a graft type treatment. So this has come a long way and has become a very popular now in the treatment of cancer. So peripheral stem cell transplant replaces bone marrow destroyed by cancer or cancer treatments, and that's done in the form of grafting. Know that stem cell patients have no means to fight infection, so you need to monitor them closely for the development of an infection. So we have some very targeted treatments, which are your biologic treatments and your monoclonal treatments. You also have cancer vaccines, such as your HPV vaccine that's out. You can have hormone replacement therapy, hyperthermia, photodynamic therapy, and gene therapy. So a lot of this has come a long way in the treatment of our cancers now. So as far as our nursing diagnosis and interventions go, cluster your activities, increase fluid intake, increase calorie intake, all for frequent small meals. That's going to be a lot easier for the client to handle, or small meals. And make sure that you are administering any antiemetics if you have them ordered. If not, try to get some ordered for the client before meals, and that may make it a little bit easier for them to eat. Know that disturbed body image can be a problem for some clients, and make sure that you are discussing that with the client and offer them any support that you can for that. Some clients may have some impaired skin integrity as a result of their cancer, their radiation treatments, so you may have to address those factors. Hair loss, as we've already talked about, prone to infection, grieving for the client, and teaching. So make sure that you are addressing those in your care plan as well. So for your terminally ill client, gently carry out those tasks to reduce any pain or discomfort. Control their pain, that should be a top priority. Offer them adequate fluid and nutrition. Keep them warm and dry. Control any offensive odors that are in the room, and by all means maintain their dignity. As we know, pain is subjective, and it has both physical and emotional components attached to that. Reaction varies depending on age, gender, and even culture, and pain can be both acute and chronic. So make sure that you are addressing the client's pain needs as it arises. Remember, pain can be neuropathic, visceral, or stomatic. Neuropathic pain is due to nerve damage, or and it can be numb, tingling, shooting, burning, or radiating. Your visceral pain is a very deep pain, and that occurs in the internal organs. It's difficult to identify or localize. It can be deep, it can be sharp or dull, it can radiate or be referred. Your stomatic pain is related to your bone or connective tissue, and it's more throbbing. It can be dull or diffuse. So palliative care is reducing the severity of or denoting the alleviation of symptoms without curing the underlying disease. Palliative care improves the quality of life. And we do this by reducing pain, by either removing a tumor or reducing a tumor size with surgery, chemotherapy, or radiation techniques. Your medications for treating cancer can be your non-opioids, your opioids, antidepressants, anticonvulsives, steroids. We can also give muscle relaxers, local and topical anesthetics as well. Medications administered can be oral, transdermal, rectal, intravenous, epidural, intrathecal, sublingual, buccal, topical, or local. And here's just a look at some other interventions that can be used when we're talking about treating a client with cancer. Like I said, you can use some anesthetics. There can be some invasive surgery such as your radiofrequency ablations and neuroleptic ablations as well. Alternative treatments can be TENS units, relaxation techniques, distractions, hot and cold therapy, massage therapy, acupuncture, hypnosis, and even peer group support is very helpful interventions for your cancer patient. So this concludes the lecture for Chapter 18, Caring for Clients with Cancer. If you have any questions, please contact me by email or text message, and I'll be happy to answer any question you have about this chapter. Make sure that you are familiar with all of the terms that are listed in the front part of the chapter, and complete your Prep U Chapter 18. In your ATI book, there is a lengthy chapter with all of the cancer disorders. We have covered all those in your previous med-surg lecture. I did make a PowerPoint slide with all of these cancer diagnoses on them, and it's kind of like a summary, and it's just for you to review and have on hand just to review prior to taking your NCLEX. I just thought it would be a little bit easier to have it in that format. Thank you for joining me today.